All right, welcome everybody to another virtual Monday lunch for Aggie Park, the week of August 10th, 2020. Before we get started with our guest today, let's get a quick update from our president, Bill Hill. Howdy, Bill.
Howdy, Logan, and howdy, Ags. Again, it's been, I think this is the fourth month that we've been since we've met at Aggie Park. Looking forward to being able to meet at Aggie Park here pretty soon. We're gauging that based upon the local rules that we have and what we're going to be able to do once we make our assessments. What I have been tracking is that there's been a very positive downward trend in the 7-day rolling averages of corona cases in San Antonio. So if that keeps moving downwards, and if restrictions are raised, we'll be looking to get back at Aggie Park here in the near future. We have an ability to hold some events at Aggie Park, and we've started some rentals, and we have to be very careful about that. So if you are looking to get together with a relatively small outing, Aggie Park's open for business, and we follow all the local and state guidelines. And recently we had a very safe memorial service for a few folks. So again, we're starting to think about opening up and getting back to Monday lunch, and we'll let you know as soon as we can get there. A couple of quick updates. First, I want to start out with the capital campaign. We've currently raised and reserved $1,084,870. So that's approximately $257,000 left to go. Based upon the Mays Family Matching Grant that we received. So to break that down, we need 25 $10,000 donors, or we need 257 $1,000 donors. So if you are in a position where you might be able to do that, I would welcome you to join our capital campaign so we can get our renovation and expansion projects started at Aggie Park. Again, you go to the website, you can find the details associated with that and move forward. Hey, look, we did get word that we're going to host a coaches night this year. It's going to be a virtual coaches night. We're going to be able to hear from the coach and get some exciting updates from there. We have not got the details associated with that. Stand by. We'll be putting it on our webpage, and we'll give you an update as soon as we can do that. You all know that Fiesta was canceled, and it was later, actually, first it was postponed to November, then it was canceled. But we ordered Aggie Park Fiesta medals, and they're in. And you can get your collector's item, 2020 Aggie Park Fiesta medal for $10. Just go to the website, aggiepark.com, and you can see the details there. Anyway, we're using those as a fundraiser. We appreciate it if you guys would sign up for them. Speaking of fundraisers, we are holding an Aggie Park barbecue fundraiser. And what it's going to be a drive-by, pick up a plate of the Aggie Park famous barbecue, along with homemade potato salad and compliments of the Aggie Women's Club and other associated side dishes. $15 a plate. That's going to be on August 22nd. So it's in the afternoon. You can pick it up. Logan, did you remember what time we are targeting the actual pickup date for those plates, starting and when?
The pickup time it will definitely be after lunch, afternoon. So I think it was noon into the early evening. That will be. Yeah,
it's going to be a 4-hour period of time. So again, details on the website. We'll have more details coming up, but that's how that works. Golf tournament is the next big event on September 10th at the Canyon Springs Golf Course. We're going to be donating box lunches, and we have plenty of room for more teams. So come out for a great day of fun, lunch, enjoy barbecue, dinner afterwards, and join us there. Another fundraiser for the club. Always a good thing. The next fundraiser is October 30th. We're going to have a sporting clays tournament. Details are on the website. Also, I think we have details of the golf tournament and the sporting clays in the last Alamo Aggie that you probably got in your mail last week. Okay, well, I'm about wrapped up. I do want to mention that applications are now available at the San Antonio A&M Club and the website for the Foundation Board of Directors and A&M Club Board of Directors for next year. So we're always looking for great volunteers to come, and hopefully this will be a good time for you to sign up. All the hard stuff will be gone this year, hopefully, and you will be enjoying a brand new, renovated, expanded Aggie Park during your tenure as a board of director. Logan, that wraps up my summary. I'm going to turn it over to you and Frank, and looking forward to this great session here.
Thanks, Bill.
Thanks for the update, Bill. And we've got a special guest with us today, Dr. Frank L. Madla III. He has a BS in biomedical science from Texas A&M University, class of 1987, with a medical degree from UT Health Science Center of San Antonio, 92. He was chief resident at UT Health Science Center from 1995 to 1996, assistant professor at UT Health Science Center from 96 to 2000. He worked at the Audie Murphy Memorial Veterans Hospital Department staff physician from 2002 to 2010, and for the last 10 years has been with WellMed Medical Group as a hospitalist, MD. So I'd like to welcome Dr. Madla. How are you doing, Doctor?
Thank you. Thank you, Logan. Thank you. As you mentioned, I am an Aggie, so howdy, Aggie friends and family. I'm also a graduate of UT, but that A&M, I'm here in my office, but that A&M degree hangs a little higher than that UT degree. But I really appreciate the opportunity to talk to you all today. It's a timely talk about coronavirus. I don't have all the answers because we in general, the physicians and scientists, don't have all the answers. But as Bill said, there is, the cases seem to be leveling off and decreasing, which is a good sign for our community. I can tell you I see it in the hospitals, just in how busy I've been over the last couple of weeks versus what I was the last couple of months. But our levels are still high, and we'll get into that a little bit, especially now that the parents and grandparents are thinking about kids going back to school. Monitoring these test positivity rates are going to be important for the safety of the kids and kind of how we feel about sending our kids back to school. So I'll touch on that a little bit here in a little bit, Logan.
Thank you.
Can I get started, or do you have any introductions?
Well, I was gonna. You kind of got right into it. And opening question was if you can kind of walk us through. Well, there's so many numbers out there that you argued one way or the other, but you're in the middle of it. You see what's going on, and if you could kind of walk us through from when the coronavirus first got on your radar to where we are now and what's been going on.
Sure. Well, obviously things started in December. I mean, anybody can look this information up. So I'm going to spend what little bit of time I have on some practical information and maybe some advice. Maybe people who are listening will take a pen and paper out. I'll have a couple of websites that I'll share with y'all and things that you may want to write down. First and foremost, why are we even here? Coronavirus is not a new virus. The virus that we're dealing with, COVID-19, is new because there was a genetic alteration in the coronavirus, something that we call emerging viruses or novel viruses. For those that didn't realize, coronavirus is ubiquitous in the environment. About every cold and flu season, about 30% of the colds that we get are thought to be related to coronavirus. Most of us get a little sick for a couple of days and then we go back to work, and we had the standard coronavirus. So somewhere along the way, there was some sort of genetic alteration in an animal, we suspect. Those things are still being worked out, but these zoonotic diseases tend to happen, especially with coronavirus, in birds, mammals, and bats. And then there's some sort of vector that carries it over to us, whether it's a fly or a mosquito. So that's being worked out. But for whatever reason, this particular coronavirus has a genetic makeup that's such that our immune systems don't recognize it. And therefore, we have these massive inflammatory reactions to it when we become infected, something that we refer to as cytokine storm. And it's inflammation that can affect all our organs. And so that's sort of what we're faced with when patients are sick enough to come to the hospital. Now, where are we at today? I don't want to get deep into the numbers. You can turn the news on. There's plenty of numbers to see. But just to give you an idea of what the effects are around the world, 180 countries are affected, and obviously every state in our country has been affected. Sort of some important data to keep in mind about coronavirus for your family and yourself is, if you get a high risk exposure, let's say you run down to the coast for a little day trip to sit at the beach because it's a relatively safe place to be in an open area, but you find out the guy you rode down to the beach with, the Corpus with, turns out to have coronavirus, and you were in that car with them for 2 hours without a mask. High risk exposure. So the important thing to keep in mind is the incubation period. The period of time between exposure and developing symptoms is thought to be around 14 days, with the median about 5 days. And so if you isolate yourself for about a week and you don't develop symptoms, you can start to feel that you got lucky and you didn't develop symptoms. And it's why the NIH has come out with recommendations that you isolate for 10 days if you should have an exposure. So incubation time, something important to keep in mind just for yourself as you think about, well, they want me to go into isolation. How long do I go in isolation for? And it's difficult to isolate. I can tell folks that haven't done it. My wife and I had to do it. Even though we have extra rooms in the house, it's very difficult not to cross paths when you got people in the same house. The other thing that we do know is that the transmission of this virus is through aerosol, through particles. We breathe, air in and we breathe it out. The COVID particle or virus becomes aerosolized. And the way we end up getting it is we're sharing each other's air, basically, or sharing each other's oxygen. You can also get it by touching inanimate objects that may be contaminated. There's controversy about how long the virus will stay alive on a particular object if, say, you sneeze or cough on it. If you go to HEB to pick up a can of corn, you're unlikely to get COVID by picking up the can of corn unless somebody has sneezed on the can within a few hours. So, I know a lot of people bring all the items home and they wipe stuff down with alcohol wipes, which is fine. Your chances of getting coronavirus are less so with inanimate objects, so than if you breathe it in, which takes me to sort of some practical advice, which are the masks, or do masks really make a difference? Because if we're saying that you spread it by sharing each other's air, what do the masks give us? Well, this question really was answered long before coronavirus came about. We have plenty of studies on this stuff. If you dig down into the data and the information that looks at masks, there's been trials within hospital settings. There's been trials that were done in other pandemics, viral pandemics. And you'll find data on both sides of the issues. The vast majority or the weight of the information will say that masks do reduce prevalence of spreading the virus, especially in closed spaces where people are very close. Now, there are a lot of different masks, so it does get confusing. But the weight of the information does lean towards that the mask will make a difference. If you go through the NIH guidelines, which is about 1.5 inches of reading, I don't know if you can see that. NIH has a great treatment guideline, COVID-19 treatment guideline that I think most doctors probably have sitting on their desks. It's updated every week. So you can simply pull out the 2 or 3 old pages, let's say on remdesivir, a drug, and put the new medicine, the new pages in there. And this stays up to date. They have articles that review everything from mask wearing to some of the controversial drugs that you see on the news. I think we talked, Logan, how you can turn 3 different news channels on and you get 5 different opinions on one drug and you don't know what to do. Well, the NIH has done a real good job about what they recommend we give as physicians and use in the hospitals, and what is out there in the media that's not so much approved or recommended, and it backs it up with data. And the nice thing is it summarizes. It's not real deep and spending hours reading biostatistics to try to figure out what to do. It's pretty clear. And it's very objective. So I would direct people that, if you're interested in reading a little bit deeper about this information on COVID, just go to NIH, just Google NIH COVID-19 treatment guidelines. As an example about how easy it is to read, this is a drug that we use. It's remdesivir. Gives you a quick 1-paragraph explanation of how the drug works, what the recommendations are by the NIH, which is hospitalized patients with low oxygen should get it. And then it backs it up with 3 or 4 with whatever research they have that backs up that decision. And it doesn't give you the 20 pages of, let's say, one particular research. It summarizes it on one page and gives you the summary so of all those controversial agents that are out there, this is the best place to go to kind of review that. And you feel better, you feel smarter walking away after you've reviewed that. So you're not going back and forth. And so they review the mask issues. There is a great review of a lot of the data that's out there on it. There was a meta-analysis that was done even 3 years before COVID. It was published in the Annals of Clinical Infectious Disease in 2017, a meta-analysis that looked at a bunch of research trials done on masks and diseases that spread through aerosolization or airborne disease. And the conclusions were that masks do help. And that's where a lot of these recommendations come from. There are a lot of masks. I can tell you that if you go into a hospital, we have a choice of 10, 15 different masks. And so you have to know when to use certain masks and how to use them. And in fact, before they allow you to go into rooms with TB patients, COVID patients, influenza patients, we wear N95 masks. These are medical industrial grade masks. This is a sort of one size fits all Home Depot brand that I got. But I can tell you in the hospital, they actually fit test us. They have different sizes. They make you put the mask on. They put this plastic thing over your head and they squirt different odors into the mask to see if you can smell them, coffee, vanilla. And if you can smell it, you have the wrong size mask. So it's very complicated on the medical side. I think for our purposes here, there are 3 common masks that I'd like to talk about. Everybody, I think by now has seen the cotton masks that people either are making at home or you buy them online. The recommendations on these are that you have 3 layers of material. Preferably cotton has been shown better than some of the other materials that are used, like an old, I don't know, an old t-shirt or old shirt that may not be made out of cotton. So cotton and 3 layers is the best. The reasoning behind that is the inside layer will provide some protection from the moisture. It'll pull the moisture away, make it more comfortable. So that's the cotton mask. Then you have what we call the polypropylene mask or surgical mask, which is also ubiquitous. People are wearing these a lot now. You'll notice that there's 2 sides to them. There's 2 colors rather. The white always goes towards the mouth, and that whatever color it is, typically baby blue, it faces out. It has a piece of metal in the nose so that you can shape it around your nose, get a tight fit, and then of course the straps go around your ear. The third type of common mask are the N95s. These are industrial grade masks. They're medical grade masks. You can obtain them as a lay person, as a non-medical person, as just a private citizen walking through Home Depot or Lowe's, or even I found some at Academy the other day. They're very limited. If you try to buy them online from a medical supply, you may get lucky. But in general, you get a message that it's they're limited to the U.S. government or to hospitals and research places. But you may get lucky and find them. Now, the first 2 masks, the cotton and the surgical mask, they will not protect the wearer from COVID. So if you're wearing these masks, which some cities are mandating these, many are not, in order for them to work for a community, everybody has to wear them. If not, the vast majority of people need to wear them because if you have COVID and you're wearing this and you sneeze, cough, or talk loudly, it will protect the people in the room. It will reduce the amount of COVID that becomes aerosolized, so it protects the room. The problem is it doesn't protect you. So if you have a number of people that are COVID positive, you're at risk of still getting COVID unless you maintain that 6 feet of distance. So the way for these to work, 100% of people need to wear them. N95 is a different deal. It protects both the community from you if you're COVID positive. More importantly, it also functions to protect you. So it has a dual purpose. The problem is attaining these things. N95, a lot of people ask what that means. I don't know if you can see that. The lettering should be on the mask when you buy them. It'll be on the package. These are ones that I bought in January before they were in short supply. One of the things I do in my spare time when I'm not doing doctor stuff or I'm school board president, when I'm not dealing with that, is I like to work with metal, grind metal, and do welding. And they usually have these packages near the welding machines. So I bought these at Home Depot back in January. You want to find the N95. What the letter stands for is whether this is oil resistance. So this N stands for that it's not oil resistant. If it has an R, it means it's resistant. So you may have an R95. R is fine. You don't care about the oil resistance as far as COVID is concerned. What you care about is the 95. They also have N99s or N100s. What it means is that it will filter 100% of particles out of the air if you breathe through the mask and not around the mask. The other thing you want to find on the packaging is the NIOSH. It stands for National Institute for Occupational Safety and Health. So that's a US, this tells you that it's a USA, an American regulatory approved mask to filter out 95% of the particles. One of the things that we did run into is, if you notice, this N95 has an actual little plastic valve on it. It's a one-way valve. You can breathe in through the mask, but not the valve. The one-way valve is with your expiration, so air is, it's for comfort. It's to make it easier to breathe out. These masks will protect you if it's a tight fit and you're breathing through the mask. The problem is if you're in a crowded room, nobody's protected from you if you're COVID positive because you're breathing through a one-way valve. I've seen people and I've seen recommendations in some of the literature how people break the plastic piece off and just put a piece of duct tape over the valve, and you basically disengage the one-way valve. And then you're breathing in and through the, in and out through the actual filtering apparatus. Duct tape seems to fix everything, I guess. The last thing I would add about the N95s is you may see this KN95. I don't know if you can see that. This is an N95 mask, but they put a letter before the N95. It says K. Well, what does that mean? Well, that means that these were certified based on China standards. This is a Chinese-made mask. If it says NIOSH, you know it's approved by the National Institute of Occupational Safety and Health. If you say the K in front of it, it's certified by Chinese regulatory standards. It does meet the 95% filtration. It is FDA approved and World Health Organization approved to work with COVID patients, but only if it has 5 layers of material. Now, it does look a little bit different than the N95. It's a little more of a cone shape to it. Getting back to the 4 to 5 layers, I found these at Academy about a month ago. I was shocked to actually see them when I saw the N95. I bought a pack. You get just to give you an idea of, you know, the supply demand on these things, a bag of 5 masks were $30. They were charging $6 a mask. So I grabbed them. We were having some shortages in the hospital. I've never been told that I couldn't have a mask, but it's getting a little bit harder to ask. You got to go through the charge nurse and sign 2 pieces of paper, hold up your left leg sometimes just to get a mask. So I get my own mask and I keep an extra supply in the pickup just in case, you know, I have too many problems getting them. So the issue with these is if you find these and you buy them, will this protect you from COVID? If it's only a 4 layer, as you notice, if you look closely, it says 4 layers of protection. The FDA and World Health only recommends 5-layer KN95s for COVID protection. I've got a 4 layer. So technically I would not feel comfortable going into a COVID infected room. Let's say if you have a family member that's, you know, in the extra room and you're, you know, dropping off lunch to them, leave the lunch outside the room. If you go to HEB with these things, do your grocery shopping, you're likely better protected with the KN95 than the surgical polypropylene masks or the regular cotton masks. So if you find them, just know they're better protection than the standard stuff, but look for the 5 layers if you can find it. If not, you know, the 4 layers probably better than nothing or better than the surgical masks. The other issue I wanted to touch on is testing. I can tell you when this all rolled out, I was getting innumerable calls from families, friends, and second cousins and uncle on mom's side and everybody else. Where do I go get tested? You know, I'm worried. You know, somebody in my office was sick. They had fever. A lot of people were showing up to the emergency rooms and being turned away because they weren't sick. They just wanted to be tested. And I can tell you, one of the ERs I work at, you basically got a piece of paper that would say COVID testing. Here's an address and a phone number. You're free to go unless you feel sick in some way. So there was a lot of frustration on people's parts. And, you know, I can tell you that when we were at the peak of our hospitalizations, a lot of patients who had very minor symptoms, let's say maybe a low-grade fever and some stomach cramps, if they didn't get admitted, they weren't being tested because the tests were being, the hospitals were sort of limiting those tests to people that needed to be admitted, that were sick enough to be admitted. So without going into, you know, if you don't have a primary care office that you can easily get access to, if the local health department doesn't direct you to someplace you can get tested, I can tell you there's a great website from the Texas Division of Emergency Management. I don't know if you can see the website there. It's TDEM, T as in Tom, D as in dog, E as in elephant, M as in mom, .texas.gov. That's run by the Texas Division of Emergency and Management, I believe, in concert with the A&M University system. It's a very easy system to find a testing site. You simply type in the address of your house or whatever address you want. You can click a couple buttons to change the radius of how far you're willing to drive to go to a clinic, 1 mile, 5 mile, 15 miles. You get a map of the county that you live in, and then all the little red pins of where the lab testing is being done. This is not necessarily all free testing. You may have co-pays if you use your insurance, or there'll be some charge. But you know, if you're desperate to get a test right away without worrying about, do I have enough cold, fever, chills, aches and pains, you know, they'll just test you despite your symptoms. There are different tests. There are antigen tests that will test for the virus. This is what we get in people that are actively infected. They call them molecular tests sometimes. So the antigen test will test for the virus. That's the one where they stick the Q-tip up your nose. It's a little bit uncomfortable. They'll put it up into the back. It goes all the way up and almost to the back of your upper part of your mouth or your oral pharynx. There's been some that are now just nasal. I can tell you that the standard of care in the ER is to quickly do the quick test. You still there, Logan? So to do the quick test, the problem with the quick test is that the sensitivity and specificity may not be what they need to be. Hey, Logan, I think I lost you. Did I lose you? You're on mute, Logan.
Sorry about that. You're good. Yes, I just stepped away for a second. Had kids.
Oh, okay. I'm
had
sorry.
kids
I'll
in the
just keep
background.
going.
I just turned the video off for a second.
Okay.
You're still
All
good.
right. Well, okay. I'll keep going with testing. Hopefully you can edit this if you need be. So anyway, I was talking about the testing. I think the important thing about the testing to keep in mind, there's antigen testing and antibody testing. The quick tests that they do in the ER, as we found out recently with the governor of Ohio, is that the sensitivities and specificities can be kind of low. I've seen some data that shows that the sensitivity can be as low as 50%. What does that mean? That means that if they test you, if you've been exposed, you have COVID, and they test you, there's a 50% chance that it's going to come back as negative, because the sensitivity is just not very good. Now, so as y'all recall, some of y'all may recall if y'all watch the news recently, the governor of Ohio was to have a meeting with our president. He tested positive because that same quick tests are not very specific either. And so you can get false positives. They didn't cancel the test. President had his meeting. They sent the governor home. He went home and got what's called the PCR test, which is a standard of care, which is a gold standard, I should say. And he tested negative. Turns out he didn't have the thing to begin with. So the 2 points to make from that is, one is if you really feel like you got COVID and you're sick and you test negative, you probably should be retested. I can tell you if you get admitted, the doctors will retest you. The PCR test is a much more sensitive and specific test. The reason why they don't do that in the ER is because it can take 4 to 6 hours to get that test back. And we really need point of care work. We need to know if you come in sick, do you have COVID? We'd like to know within an hour or 30 minutes, are we dealing with a COVID patient? Because there's a domino effect through the hospital about isolation rooms, reverse isolation rooms, people having to wear full PPE, not just the mask. And so making decisions in 30 minutes is a lot more helpful to us than waiting 6 days. The antibody test is a different deal. If somebody finds some tests that is being sold on Amazon or wherever, they probably are antibody tests. Those do not tell you if you have active disease. What that tells you is that you've probably been exposed to coronavirus. You've recovered, and now you have antibodies, which are proteins that we all make when we're infected with something, whether it's a toothache, an earache, you make antibodies to the infection. The problem with those antibody tests is you could have antibodies to coronavirus from a sore throat you had a year ago. So you don't know, is it positive from the COVID-19 or is it positive because of the sore throat you had a year or 2 years ago, and you're still carrying a few antibodies. So it's a relatively useless test as far as diagnosis. If you do get it, you probably will get it as part of a vaccine trial, because that's what we're testing for. They're going to give people vaccines, and then they're going to test for antibodies to see if you make antibodies, and then they're going to test to see do those antibodies actually prevent people from getting infection and saving your lives, reducing mortality. So if you're in a vaccine trial, yeah, you'll get antibody tests. Also, if you're someone who's recovered from COVID-19, convalescent plasma is something that's real important in the treatment protocol for COVID patients. What convalescent plasma is that we take people that have recovered from COVID-19 and they give a blood transfusion. We take the blood, and as give you an example, if I were to take a test tube of somebody's blood and spin it, what you'll get in that test tube is the bottom 40% of it will be red blood cells, pure red blood cells, which carry oxygen. There'll be a thin layer of white cells, which are leukocytes, or help us fight infection. It's the top portion that we want. That top 55% of the blood is plasma. That's the liquid portion of our blood. It's full of antibodies, albumin, the antibodies that help fight infection. In this case, we want the antibodies that fight coronavirus. So the South Texas Tissue and Plasma Center down the street will take that plasma and will infuse it into somebody who is actively infected. And we find that there's some benefit with that I'll get to here in a second. So those people, before giving their plasma or their blood, will be tested to see if they have antibodies, because if they have none, we don't really, the blood is useless to us. We need the antibodies. So in that case, you may get tested. And just as a side note, so I don't forget, if there is anybody who's had COVID-19 who's listening amongst our Aggie family or friends, please give plasma. One of the things that we ran into probably about a month ago, I'd say the last couple of weeks, not so bad, is we now have an agent that helps, that does reduce mortality, but we were running out of it, and we were ordering it for some of our patients, and they were having to wait a day or two in order to get it, because it wasn't available. That problem has eased a little bit now. As Bill said, the numbers are coming down. I can tell you the hospitalization numbers are coming down. I looked at some numbers about 3 days ago, and we had a decrease of like 13, 14% in hospitalizations, numbers of people that are on ventilators and that sort of thing. So the trends are going where we need it. And hopefully people will keep doing the masks and the stuff that we need to do. So that's testing. As far as prevention, the only thing a couple quick things. Currently, there are no medicines. We have no vaccines. We have nothing to prevent the disease, whether it's what we call pre-exposure prophylaxis or post-exposure prophylaxis. Pre-exposure prophylaxis are things like a vaccine that you take, and now you're protected. You can go out and do what you want with no mask, and your chances of getting coronavirus or COVID or whatever you've been vaccinated for, influenza, is less likely. Post-exposure prophylaxis are things as if you had a high-risk exposure, you can then take a medicine, and it would prevent you from converting to an active disease or seroconverting. We don't have anything approved or proven to work. I mentioned to my wife the other day that we use vitamin C, vitamin D, and zinc in some of our coronavirus patients based on old data with other lung diseases. NIH, I can tell you, does not recommend using those based on the preliminary data we have. I can tell you some of the hospitals are still using the vitamin C, D, and zinc, although it's not proven yet for COVID. So you got to be careful what you say around people, because my wife came home with a bag of vitamins. And so I've had to, have her stop the vitamin D and C. It's not proven. And so, save yourself some money until we get better data on that. What's coming down the pipeline is vaccines. There's a lot of vaccines in the pipeline, more than we can talk about tonight. There is one that I think everybody's probably heard of on TV now, on news, from Moderna. It's a collaboration between Moderna and the National Institutes of Health. The only reason why I mention it is because it's the first phase 3 trial vaccine. Another, for those that don't know, any drug, any medical device, any vaccine that's approved for human use has to go through 3 phases, actually 4 phases of a trial, but a drug has to go through 3 phases before it's approved by the FDA. Once it gets to that 3rd trial, it's released to the public for use. And then the 4th phase is simply monitoring the mass use of this across a community, a nation, to see if there's anything that we missed during the first 3 phases of the trial. Typically, vaccines take years to develop. Most drugs take years of development. To give you an idea of how fast the president's vaccine development process has been, I think they call it Operation Warp Speed, and it's truly been warp speed. The phase 2 trial on the Moderna vaccine started in May. And by the late July, early August, we were already in phase 3, very quick. Basically, what you establish in the phase 2 is you determine the safety and dosage and whether it's actually effective in producing what we want, which is the antibodies. And now during phase 3, we're going to find out if this thing works. It's probably going to take a little bit longer to get through phase 3 for those that have kind of, we're all waiting for this vaccine to come through. Moderna's vaccine is going to recruit something like 30,000 patients. They're going to do that at 89 sites around the country. They're obviously looking for areas of the community, areas of the country where there are higher rates of coronavirus, because after you vaccinate these folks, you want them to be exposed to it to see if it works. So it's going to take time to gin up those 30,000 patients. It's going to take time to get them into the protocols. And they're not just looking at, does it prevent the disease? Some of these people will be getting 2 injections, one on day 1, one on day 28. So that will move that arm of the trial down at least a month. Some people will get 1 shot, and then we'll see if this stuff works. I hold out high hopes that it's going to work. I have a lot of respect for the folks at NIH, especially Dr. Fauci. I can tell you he was somebody that I followed closely when I was in training back in the 80s and 90s when we were dealing with the HIV/AIDS pandemic. It was Fauci and NIH that really put together these sort of treatment protocols that we followed and helped us get through that. So the vaccines are coming and hopefully they're here soon. Just quickly to wrap up, treatments. If you get admitted to the hospital, what can you expect? The best thing is, don't catch it. Hopefully don't get admitted. For families that have been affected by it, they already know. For families, for people that still have family members in the hospital, hopefully this will give you a little bit of insight into what's going on. Currently, as I said, as it applies to therapy, there are no FDA-approved drugs for COVID-19. Everything that we're giving is still investigational. Although we do have data on 3 drugs that we're using that either improve survival, it speeds up the time to clinical improvement, and some of the treatments actually are better at simply keeping you off a ventilator, which goes a long way to getting you discharged from the hospital. If you walk into an ER sick, the first thing the doctor is going to do in his head is put you into 1 of 5 cubby holes. They refer to them as severity of illness categories. Either you have no symptoms, or you have mild symptoms, moderate symptoms, severe symptoms, or critically ill symptoms. If you have no symptoms, you're probably not in the ER. If you have mild symptoms, you're going to be sent home. Moderate symptoms or worse, moderate, severe, critical, you're going to be admitted. So what is moderate symptoms? Moderate symptoms are, you can have any number of the minor symptoms, fever, cough, or fever, sore throat, aches and pains, diarrhea, nausea. To have moderate symptoms, though, you have to have lung involvement. You either have to have a deep cough, you can have shortness of breath, dyspnea on exertion, which is shortness of breath with exercise, or pleuritic chest pain, pain when you take a deep breath, or chest x-ray findings. The difference between moderate and severe is you have all those lung findings, but now you have low oxygen. less than 94% saturation if they put the little O2 sat monitor on your finger. Sometimes they'll draw blood from your wrist out of the artery to check an oxygen level. So if your oxygen is low, you're considered severe, and if you're critical, you're critical. You're going to the ICU, probably on a bed. So what can you expect to happen if you get admitted? Well, first and foremost, you're going to be isolated. That's straight out. If you have no symptoms, mild to no symptoms, you're going to go home. The treatment is conservative. We treat the symptoms: Tylenol for the fever, Phenergan for the nausea, lots of Gatorade, chicken soup, and tincture of thyme. If you get admitted, you're going into an isolation room, and it's truly isolation. It'll be a reverse negative pressure room where air is sucked into the room, doesn't blow out into the hallways. You won't have visitors other than the doctor and the nurse. Everybody will be in full PPE. You won't see a face for the weeks or the months that you're in the hospital because everybody's covered up. If you do have a family member, I think it's important to get telephones to them and a charger. We spend a lot of time as doctors and nurses with family members over the FaceTime with the patient so that we can all visit. Everybody seems to bring the phone but forget the charger. That becomes an issue of charging up people's phones. So that's that. They're not allowing families into, I'm pretty sure all the hospitals as of now. I haven't worked the past couple of days, so things could have changed the last 72 hours. But for the most part, family members are not allowed into the hospitals. So you are truly isolated alone in these rooms while you're there. If you get lucky, you will have a roommate who also has coronavirus. It's called cohorting. There was a period where we were getting pretty tight on beds, and so they cohorted the patients. And there's something called proning, which some family members will see and think that we're being cruel and punishing the patients. Proning is a concept where they put you on your stomach. And the purpose for that is it actually can improve air oxygenation. It opens up the alveoli, the air sacs in the back part of the lungs, which tend to collapse when you're laying in bed a lot. That's why when you're in the hospital, they're always trying to get people out of bed and get you walking down the hall so that you expand your lungs. So if you end up in a hospital on oxygen, short of breath, you're probably going to be prone for a few hours every day where they make you lay on your stomach. Patients that are on ventilators can be prone for up to 12 hours, 16 hours laying on your stomach. Of course, you're sedated if you're on a vent, so you don't really know and you probably don't care at that point. But if you see a family member on their stomach, it's part of the treatment protocols. The 3 treatments that we have, let me just review those because if you get coronavirus, you're probably going to be offered these. You might be if you're admitted, and you may have family members receiving them. The first one is remdesivir. Remdesivir is an antiviral, and so the concept behind giving an antiviral is you try to reduce the replication or the division of the virus so that your body has less virus to fight. Now, if anybody's ever gotten Tamiflu before for influenza, you know that the sooner you start the medicine, the more likely it is to work. So for people who've had influenza, their doctors may have told them, look, you have to start it within 48 hours of onset of flu. Remdesivir is no different. The sooner you start it, the better it will work, the more likely it will work. They give you up to 7 days to start it. If you're beyond 7 days of symptoms, it's an exclusion criteria because there's no evidence that it's going to work, and number 2 is there are very limited supplies of remdesivir. So it has to be started within 7 days. There is data on this. There's actually very large data on it. Once again, it's all summarized in NIH, but there was a multinational trial with something like 1,000 patients, and the clearest benefit was seen in people who started the treatment early, within 7 days, but people that had severe COVID disease. Once again, those are the people that have lung involvement and they have low oxygen. Interestingly enough, it also showed that the time to recovery was a lot less. So if you get admitted, you're likely going to be offered remdesivir if you have low oxygen. And there was also a trend towards survival. So people who took it were more likely to survive with remdesivir. The third treatment is convalescent plasma, which we talked about earlier. We take the plasma from people that have been infected and we give it to people that are now actively infected. The way that this works is the antibody will bind the virus and neutralize it. Once again, your body now has less virus to contend with and fight. There's data on that. There's two trials. One's a large safety trial that was done out of, I think, the Mayo Clinic, 20,000 patients. They found it to be a safe treatment. Less than 1% of the people had severe reaction to it. The clinical trials that showed benefit were very small, but the trials that were done on that were done out of Mount Sinai, New York, during March and April when New York was dealing with what they were dealing with. And there was actually an improvement in the mortality. So people were more likely to survive severe COVID if they were given convalescent plasma. And once again, the biggest thing that we're contending with is supplies. So if people have had COVID, please go and give COVID, please go give some plasma. The last thing are steroids. Once again, steroids is one of those things where if you dig deep enough in the data, there's data that says steroids are great for lung infections and there's steroids is not great for lung infections. Well, that's true, depending on what disease you have. As an example, for pneumocystis pneumonia, which is a very rare pneumonia in the general public, but is common in people with AIDS, those people show up with low oxygen levels, steroids will save their life. It improves their survival. If you give steroids to people with plain old influenza, which we deal with every year, the flu, or people with MERS, which is Middle Eastern Respiratory Syndrome, those people do worse. And in fact, steroids are contraindicated in people with influenza. You don't give it to influenza patients. What we're finding with COVID, first of all, it's a steroid, and so it reduces inflammation. And because you have a massive inflammation in COVID-infected patients, the thoughts were that maybe it'll help. And sure enough, it does. It's a 10-day course if it's offered to you. There was a very large trial out of UK, 6,000 patients. It was a recovery trial. What it showed is that there was a reduction in survival. I mean, there was an improvement in improvement in survival in patients that had low oxygen. Once again, people that are severe disease, lung disease, low oxygen, they do better. They're more likely to survive if they get steroids. And I can tell you that when I'm on call, even before I call the lung doctor or the infectious disease doctor, if I get a call that I have a positive coronavirus patient, even before I go in and see them, I'm putting in orders. If their oxygen is low, I'm putting in orders for that first dose of Decadron, either in their vein or by mouth, before I even get there. Let's just get it started. A 10-day course. Interestingly enough, if you get admitted with lung findings, even a chest x-ray with lung findings that show that you have pneumonia, if your oxygen levels are normal, those people didn't seem, for whatever reason, to have improvement in survival. Early data, there's a lot of data to come yet, so there may be others that benefit for the survival. And the survival benefits in people that had low oxygen was it actually a decreased chance of death by 30%. So it's a significant agent that we have to get people better. So 3 things that you may hear if you get admitted. Once again, the remdesivir, convalescent plasma, and the last thing would be the steroids. How am I on time, Logan?
You're doing good.
Okay, the last thing I want to talk about, I know it's a big deal, is the school. I spent a lot of time this week reviewing data for schools because I got grandkids and I worry about it. The other thing is I've got 500 kids down the street on the south side of San Antonio at a small charter school that I'm responsible for as president of the school board. So I've got not just my daughter asking me, I've got, 500 moms and dads down there asking about what are we going to do? What do you think? Well, I can tell you where we're at. We've got a lot of, a lot of advice, I guess you can say. The CDC has their guidelines. The TEA has theirs. We have the local San Antonio Metropolitan Health District that has theirs. A lot of it's very general. I can tell you that I read through all this stuff. The CDC recommends that we open schools or not open schools based on 1, 2, 3, 4 levels of community transmission. They rate them anywhere from no transmission to as high as substantial uncontrolled transmission, but they don't define what that is. Does that mean 5% positivity in the community, 10%? And in each section, there's not a whole lot to add because what can you do right now? Social distance, masks, and wash your hands. So no matter what level you're in, it's pretty much the same thing until you get to the worst case scenario, which is substantial uncontrolled transmission. They say call your local health officials. So we're blessed with the San Antonio Metropolitan Health District that's been very active in this. I sat in a meeting this week. They've broken down, instead of to the 4 sections that the CDC does, they've broken it down into a red, yellow, green zones, red being that we have a population, a community that has a lot of coronavirus, that we should not be offering in-person instruction. They don't define what red zone is, at least in the paperwork and stuff that I have on it. Yellow zone is kind of a medium risk community. They're saying that at that point, they would recommend 25% occupancy in the building with 6 or fewer students per classroom. And then the green zone, they do define as a positivity rate of less than 5%. In other words, if 1,000 people in our community are tested, less than 50 of those 1,000 people will be positive. That's a less than 5% test rate. You prefer that to be over some period of time, 14-day period. And in that case, and they say open things up, we're good to go. So with that said, we've also been told by the Attorney General's office and the folks in power of our state that local health departments don't have the authority to close the school down. So those decisions are going to be pushed down to the school board level after discussions with families, with superintendents. I can't speak for all the school districts. I can tell you that we took a questionnaire of our little school, and 20% of the parents feel comfortable sending their kids back. I know that there's some other ISDs like Bernie and Comal schools. They're going to open up right after Labor Day. So, you know, there's different feelings in different areas of our state, and time's going to tell. I know that Northside Independent School District, my granddaughter goes as of Monday morning. You're going to have to decide whether your child's staying home and doing web-based teaching, or whether they're going to go into the classroom after Labor Day. TEA, Texas Education Agency, and the governor has allowed us to keep the kids at home until Labor Day. Everybody, 100% of the kids will be at home web-based starting in August. Everybody has different start dates. I don't know if you have kids, Logan, so you probably know all this stuff. But come Labor Day,
I've got 3, but they're 4 and under. So I got my
oh, okay. So we'll get through this. By next year, this will all be blown over. So come Labor Day, though, the governor is asking us to start sending kids back into the classrooms. How that looks, you know, you open up 100%, do you open up partially? The guidance that we have in San Antonio is the red, yellow, green from the metropolitan. I'm assuming every district, every county kind of has their approach. It's not standardized. After Labor Day, the governor did recently say that the school boards have an option of extending stay-at-home web-based teaching for another 4 weeks beyond Labor Day, depending on what the local the parents and the teachers feel comfortable doing. So we may have that. Some school districts, I believe Harlandale and Southside ISD has went ahead and extended it. Areas in Comal and Bernie have not. They're going to start and there's everything in between. So that's kind of where we sit. Just to give you an idea where San Antonio sits, our numbers are coming down. Bill had mentioned that earlier. I think that some of the things that the community has done, people are living smarter and doing, following hopefully most of the recommendations. But where we still sit as of August 6th of 2020 in Bexar County is that we have a 13.7% positivity rate. So, so once again, remember that sending all 100% of the kids back into the school, they want us to be at 5% or less. We're at almost 14%. Hopefully by Labor Day, we're at that magic less than 5%. If not, I can see a lot more schools maybe extending home teaching. And that's kind of where we're at. It's not all grim. We'll get through all this. I can tell you, I've been through, this is not my first pandemic. I had to deal with the AIDS pandemic as a young student. At one time I was young and skinny like you, Logan, and I scared because I didn't know anything. I was a young medical student, but we got through it. I mean, we didn't think we were gonna get through it, and you did, just, you know, following guidelines from NIH and CDC and people like Dr. Fauci, who I have a lot of respect for. So we'll get through this. We just need to follow the recommendations of our doctors. You know, do our best to wear the mask and the things that we have, because they're the only tools that we have right now. If you do get admitted, know that there's 3 drugs that can make a difference for you. Obviously, getting diagnosed earlier is better because the antivirals have to be done within 7 days. And probably the last thing, if you want to stay informed, there's 2 sites When it comes to the trials, if there's any doctors or nurses in the Aggie family that are listening, there's a website, clinicaltrials.com. That's with a capital C and a capital T as in Tom, clinicaltrials.com. It literally has every trial on COVID-19. I looked that up 2 days ago. There was something like over 2,900 trials on COVID-19. So if it comes to these controversial drugs and agents, you want to know, you can spend your weekend reading 2,900 trials and try to figure it out yourself. The easiest thing, though, to do if you want to keep up is the NIH treatment guidelines. It's succinct. It summarizes everything that we know in 200 pages. You don't have to read all 200 pages, obviously. If you have a very particular question about a very particular treatment or even masks, you just go to the table of contents and look up that page and read that one little page or 2 pages. So that's what I have. We're going to get through this. The last thing I would say is we will have a vaccine here soon in the next, hopefully 6 months or so. I would recommend people take it because that's going to be our easiest way out of all this and the fastest way out. So we can all get back to our barbecues and Monday lunches and you know, shake hands and high five and do what we do and get back to football. Logan, this is painful. This is going to be I had season tickets for as long as I can remember. This is going to be hard.
Especially if they cancel the season. I know they've moved it to an in-game season of conference games. And
yeah, I've heard they're going to have to do social distancing. So there's going to be obviously people that are going to be excluded. I think what I've seen is that students are going to have first priority, which I agree with. But man, it's going to be hard to go without our football this year.
Well, these are tough times, and although it hits home to us, that's one of the least of our worries, I guess.
Yeah, it's the least. I get it. I know.
But
I've been having to watch old football games on TV. I'll tell you, that's just.
I've been doing the same thing.
Yeah.
Real quick, just to kind of switch gears. Thanks, first of all, for that comprehensive update on COVID. But a couple other things that I thought we could talk about, and one was.
Sure.
One was when you're not in the hospital taking care of patients, you're very involved with community, and one of those is that you've been a board member at Texas A&M San Antonio since the inception of the school. You've seen the first 10 years your enrollment has grown exponentially. What's the next 10 years look like for A&M San Antonio?
Well, it's hard with this COVID. I think the growth, a lot of the momentum obviously has slowed. I know that they're going to be having, I've kind of talked to I haven't talked to Dr. Matson, the president, directly about it. I've been talking to people sort of in her inner circle about it. I still have connections. I'm no longer on the foundation. I was on the foundation for 10 years from its inception. They limit you at 10 years. So I think I went off at the end of 2018. So I think once we get through this, once we get through this COVID, the momentum will kick back. There was, a lot of excitement those first. My father was the senator that wrote the legislation to bring it. I can tell you that there was a lot of excitement, even when they were in portable buildings. The first day they opened the buildings, they didn't have enough space. After they built the first actual building, which they call the Madla building, they didn't have enough space because students kept coming. And so I don't know if you've been to the campus, but they're up to now 4 buildings. Of course, they have the dorms now. We just need to get through this next semester and get through this infectious, issue that we're dealing with. And I see great things for this campus. I think it's obviously it's the only campus that's in an urban area. It has a lot of potential.
It's a beautiful.
Yeah, so I look forward to getting involved with the stuff again. I miss some of that too, the golf tournament that we did every year and the luncheons and just the camaraderie with the students. And I have quite a few of the students. Well, I shouldn't say quite a few now because I've been so busy with this COVID, but up until this, I had quite a handful of the students that would follow me on rounds, students that were interested in medical school or nursing, one young lady that was physical therapy. So I miss some of that camaraderie, having students to kind of follow me around. One of the young ladies that got accepted to medical school should be graduating, I believe, this year. I don't know if she's the first doctor coming out of A&M San Antonio, but she's not the first. She's close to it because she was accepted some 3 years ago. So.
I believe I got to meet your father at the San Antonio A&M golf tournament, playing with Harold Oliver. And
Oh, must have been, yeah. Well,
and
he's passed away some years ago, so it must have been one of the first early
it was, it
ones.
was, it was
Yeah,
one of the first ones
yeah.
that Harold invited me to. And you mentioned the Madla building, beautiful building on campus, um, and that's something that kind of hits real close to home with the San Antonio A&M Club, because one of our board members from this last year, the late Greg Garcia, passed away, class of '62, and it's to my knowledge that they're looking to name one of the floors in the Madla building after Greg Garcia. Is that correct?
Yeah, we are. He passed away in October. Greg and Margaret, I'm sure most of y'all know Greg and Margaret. They were pretty regulars there at the club. Greg was probably 20, 25 years my senior, but I can tell you he was one of my best friends. He introduced me when I was just a young and skinny kid in high school. He introduced me to tailgating at A&M, introduced me to A&M, introduced me to sorority girls, introduced me to everything that was great about A&M and Howdy's and the chicken. And Greg became a friend. He really was. He was my father's best friend. He was my father's campaign manager for 33, the whole time that my father was in politics, for 33 years. When my father passed, Greg and Margaret became literally my best friends and my wife's best friends. We were season ticket holders at A&M football. Greg Garcia had a tailgate, I think, for 41 years straight or something crazy like that. We were at every one for the 15 years that we hung out with him. He was a great guy. He was an Aggie through and through. He truly lived in an Aggie way of life. It was all about, tradition and honor and excellence, integrity, and all the things that make up the Aggie way, the core values of A&M. So when he passed away in October, it was a big loss, not just for us personally. It was a big loss to A&M San Antonio and the A&M University system. He had worked in governmental relations for many, many years at the university level and at the A&M San Antonio level. My father would write the legislation that created a university in the South Side, but it was Greg Garcia that made sure it was A&M. My father had no loyalties to A&M. He sent his son to A&M and he sent his money to A&M. My father didn't go to A&M. He was a school teacher as well as a politician. All he wanted was a university in an area that was underserved. But it was Greg Garcia that said, Frank, if you're going to do this, let me make sure that it's A&M. Let me talk to the people that I know at A&M. And so Greg did his magic on the A&M side, and Dad did his political magic on the political side. And we ended up with an A&M in our backyard, which is a great opportunity for the kids in that community. So when he passed away in October, it was a huge loss. We approached Dr. Mattson to see is there some way that we can honor him. We'll try to get some fundraising around it, whether it's for scholarships and endowment. We came up also with an idea of a visual tribute. You mentioned the hallway. I think I have a flyer here. One of the things they mentioned was having a hallway. If you can see that, the Greg Garcia Founders Hallway, where we will honor people in that hallway that have helped bring the university along. We're going to be trying to raise $50,000 for those endowment scholarships, the hall, or what we decide to do. And the university has offered to match it with $25,000. So we're packaging up together those asks and those flyers. And of course, I'd love to have an opportunity to present that to the Aggie family, the club, and if anybody's interested in helping out with that. And I think it'll be a great tribute to a great Aggie, a great man, a guy that was just really good. He helped so many students. Like I said, he drove me to A&M to introduce me to A&M. He did that for many, many students, many, many students. I recall stories of a young man who were going on their first interview, couldn't afford a tie or a suit, and he'd give him his maroon tie for the interview. That's how Greg was. So yeah, we'll be working on that, and I appreciate the opportunity to introduce that to the Aggie Club, and just keep Greg Garcia in your thoughts. Class of '62, and he lived the Aggie way for the very end. Dressed in maroon all the way, head to toe. Maybe some khakis every now and then, but always in maroon.
We were fortunate to be able to serve. Me and Bill be able to serve with Greg Garcia and get to be see him in a leadership role in what he's good at. He's always there helping everybody and anybody wherever he can. So great guy.
Well, I appreciate those comments, Logan.
Well, Dr. Madla, thank you very much. I know with all the boards that you're on and the work that you do, your time is very important, and thank you for sharing that with us and talking to the Aggie Club, and we really appreciate it.
Sure. Anything. And Logan, if anybody has questions about any of the stuff I presented and they're like, I'd really like to see this trial or the proof of it, I can gain, it's easily accessible. I have it sitting on my desk. If you text me, hey, what's the data on, I can just text you here. You look it up yourself kind of thing.
Great.
All right.
I'll get y'all in touch. Bill, you got any words before we leave?
Well, you know, not really. I just want to thank the doctor and for serving, you know. You're clearly somebody that can live by the motto, I'm here to serve. You serve on board of directors. You're a doctor that you're saving lives. It's got to be very, very difficult. Thanks for agreeing to provide us a summary and an update. It was very, very interesting and valuable. But mostly, I just want to say thank you. Thank you on behalf of everyone in San Antonio. Thanks for all you do. You probably don't get told enough, but thank you very much.
I appreciate that, Bill. Appreciate that. I wish my wife was here to hear that.
Hey, it's on those. It'll be on aggiepark.com. You can go be able to check it out.
Make sure she hears that.
All
All
righty.
right, guys.
Thank you, guys. We'll talk to y'all. We'll see y'all later.
All right. Good night, guys.